So welcome everybody. My name is Susan Barber and I'm the Community Education Manager at Mission Hospice and Home Care. And for those of you that live in San Mateo or Northern Santa Clara County, I'm sure that you are pretty familiar with us. And if you're not, welcome. For those of you that are joining us from outside of the area, we're a small, non-affiliated, which means we're not associated with a large hospital or healthcare system. We're a small hospice that cares for people in San Mateo County, which is the county just south of San Francisco, and also for Northern Santa Clara County, aka Silicon Valley, and the home of Stanford University. In addition to our hospice care that we provide at home or in facilities, we also have a beautiful hospice house where we care for 6 people who live there until they die, and their families are able to come and visit them, which has been a wonderful gift for people who have not been able to do that because of COVID-19. And with that, I'm going to ask Lucy to join us. Hi, Lucy.
Hi.
Welcome this morning.
Good morning.
I'm so grateful in the middle of all of the things that you're doing, that you're taking the time. We had scheduled this in March, and Lucy was generous enough to change her schedule. I know she's home with her daughter this morning, so welcome. Just as by way of introduction, Lucy was kind enough to send me a bio, which I'm very grateful for, because I knew some of the work she's doing, but I had no idea of how much work she's doing. So Lucy is a clinical associate professor of medicine at Stanford University and an advocate for culture change around healthcare value. She's also the widow of Dr. Paul Kalanithi, who is the author of the New York Times best-selling memoir, When Breath Becomes Air, which was also nominated for a Pulitzer Prize and translated into more than 40 languages, and for which she wrote the epilogue. Lucy is a graduate of Yale School of Medicine, the University of California, San Francisco Internal Medicine Residency, and a postdoctoral fellowship at Stanford's Clinical Excellence Research Center. She's also a fellow of the American College of Physicians, a member of the Alpha Omega Alpha National Medical Honor Society, and an honoree of Mass General Cancer Center's V100. She's implemented novel healthcare delivery models in primary care, hospitals, and healthcare systems. And she serves on leadership boards for TED-Med, the Coalition to Transform Advanced Care, and the American College of Physicians. Dr. Kalanithi has appeared on stage at TED-Med, on NPR, PBS, NewsHour, the Yahoo News with Katie Couric, and in the New York Post, the Wall Street Journal, Elle, and the New York Times. Her new podcast, Gravity, explores narratives of suffering and is in development. She lives in the Bay Area with her kindergartner. And I want to just also mention that Lucy has done all of this work while raising a tiny human being. Her daughter, Katie, is now 5 years old and a kindergartner, so congratulations.
Thanks, almost a first grader.
Almost, I was gonna say, did she graduate from kindergarten, or is that coming next?
It happens in 2 weeks. We're doing a drive-by.
Yay.
Mm-hmm.
So I could talk to you for the rest of the hour and a half just about how did you manage all of that as a mom. But I want to start just to ask you, as pretty much I would imagine most of the folks in this room have read your husband's beautiful book. And what was it like for you and Paul, both physicians, both at Stanford? He had an incredibly promising career, and then he had to make a move from physician to patient. I'd love to know more about that, and I would like to know also, what was it like for you to move or to expand from physician to now caregiver, wife, and then expectant mom during this journey with Paul?
Yeah, and thanks so much for having me. I'm so thrilled to be here and join you and the people listening this morning. Thanks. Just to check, is my audio okay? I have like an intermittent echo, but I'm just going to ignore that. Okay, you'll tell me if it's not.
Yes, it's fine.
Okay, thanks. So can I read for a second?
Beautiful, yes, yes.
I just want to read, because you asked about, the transition from, or the expansion. I liked that word that you just used, actually, from being a physician to also being a patient. And I just wanted to read about that moment, because Paul starts out the book, the prologue to the book, by talking about that exact moment. And then maybe I can reflect on that.
Yes.
So I'm just going to read. And also it's just nice to, bring Paul's words into this.
Absolutely.
As well, of course. So I'm going to read the very beginning and then the closing of the prologue to the book. So he starts out by saying, I flipped through the CT scan images, the diagnosis obvious. The lungs were matted with innumerable tumors, the spine deformed, a full lobe of the liver obliterated, cancer widely disseminated. I was a neurosurgical resident entering my final year of training. Over the last 6 years, I'd examined scores of such scans on the off chance that some procedure might benefit the patient. But this scan was different. It was my own. Yeah, I want to find the part.
Yeah.
Okay, here we go. I received the plastic arm bracelet all patients wear, put on the familiar light blue hospital gown, walked past the nurses I knew by name, and was checked into a room. The same room where I had seen hundreds of patients over the years. In this room, I had sat with patients and explained terminal diagnoses and complex operations. In this room, I had congratulated patients on being cured of a disease. In this room, I had pronounced patients dead. I had sat in the chairs, washed my hands in the sink, scrawled instructions on the marker board, changed the calendar. I had even, in moments of utter exhaustion, longed to lie down in this bed and sleep. Now I lay there wide awake. A young nurse, one I hadn't met, poked her head in. The doctor will be in soon. And with that, the future I had imagined, the one just about to be realized, the culmination of decades of striving, evaporated. I have a lot to say about that moment and what that all meant. I think one thing that was very striking to see, and I imagine that there are many people, if not all, on this call who have a sense of this, was sort of what it feels like to have the news of your sort of certain mortality at a time when, or in a life and a body where that can be a little bit abstract or forgotten or not present moment to moment. And when Paul talks about the future I had imagined evaporated, it's wild because it's like you're the same person you were 5 minutes ago, but yet you're also a totally different person. And I think some of that in a moment of upheaval like this has to do with the fact of how, for many of us, our identity is so tied up in a future conception of ourselves, you know, like what we are striving to become, whether it's as a parent or somebody who's proceeding through an education, or just so many of the endeavors that we undertake in our lives are necessarily driving toward a future. And that reflects back into who we imagine and conceive of ourselves to be in the present. So I think to have that fall is wildly disorienting. And so one of the things that Paul writes about in When Breath Becomes Air is thinking about reshaping identity and trying to forge a new identity in the context of failing body. And so that was just remarkable and upending. And then I think one other thing that became immediately apparent was how much our training as physicians wouldn't help. And I don't even mean that as an indictment of medical training or medical education. I actually just mean that there's an expertise that comes from being human. And I think or that is like necessarily found in uncovering what it means to be human in relationship and in, you know, I think the discovery of how to understand and come to terms with your mortality is not a scientific one. And I know in Paul's writing, he says something like trying to make sense of mortality through statistics, you know, through grasping at the Kaplan-Meier curves is like trying to quench a thirst with salty water. And I'll just like read people into one tiny bit of that. And Paul's sense of that immediately was when we had a sense of how serious Paul's illness was and was becoming. This was before he'd been diagnosed with cancer, but he was admitted to the hospital for expedited workup. And that was where where we looked at the scan, was in this hospital room, of course. I was packing up for that hospital stay and packed like phone charger, insurance cards, like comfy socks, a pillow, like the material objects
Mm-hmm.
for a hospitalization that you might think of in advance. And Paul actually packed books. So he took this little stack of books with him, and it wasn't medical texts. It was Mere Christianity by C.S. Lewis, Being in Time by Heidegger, and a novel by Solzhenitsyn called Cancer Ward. Sort of thinking through the various aspects of contemplating serious diagnosis. And I took a photo of the books on that little like sliding, like unsexy side table in the hospital, and then came across it later and sort of reflected on like, wow, what a prescient, important thing to hold on to these texts. So, which ultimately then became a core part of his writing was coming to terms with illness through words and through literature and through the like historical coming to terms that other people have done too. So there's some reflection on that.
Yeah, I see this book being one of those books that people will take with them, thoughtful people who are considering their mortality, not in terms of, oh my gosh, we have to do, and not just but in addition to, oh my gosh, we have to do everything at this stage for me to be alive, but also as a human being that's in this particular place and time, what is of most value to me? And, maybe, and that just, you reading that, I read that part when I read the book, and it just gave me like goosebumps all over again. As if he may have had this foreshadowing of what awaited him, and to be in that place where he had provided so much care for people, and then to actually be in the bed. And I think, working in hospice, I see some of the people that are not most difficult in sort of a personality way, but that's most difficult, I think, are for people who have to make that change from somebody who's been the carer to being the person receiving care. And I know for you also, lots changed because you, we were talking about how Paul was, he's a physician, and then he's also a patient, and for a while both. And then more predominantly, he was receiving care as a patient. But you continued to work as a physician and then became a caregiver. And I'm wondering how, what was most helpful? Were there things that you and Paul did or conversations that you had that made those many transitions successful, that worked for you?
Yeah, sure. So, right, I didn't answer your question about becoming a caregiver. So I guess a couple of thoughts there. So I remember Paul also said something important that I held on to since, or it was just like materially so helpful at the time. So he kind of early on said to our families, at least, everybody else has to take care of Lucy so Lucy can take care of me, which was very helpful in a recognition of what it means to be a caregiver and what it takes to be a caregiver. And I do remember feeling so relieved when people recognized my role in that. Like I remember going to Paul's oncologist, and she said something like, "How's the new medication working out for you guys?" And it was really helpful. It was like, yeah, it is like, it needs to work out for us. Or like, I guess what I mean by that is like, I'm trying so hard to have it work out for Paul. So like,
Yes.
thank you for, and I'm the one who's like, delivering it to him when he needs it and that kind of thing. So that was so helpful, as you know. And then I think, I think a lot about caregivers and policy or lack of policy around caregiver support. A couple, you asked what was helpful, and like two things that immediately come to mind that were helpful was Paul's employer, which was the Stanford Graduate Medical Education, like the arm of Stanford that employs residents and fellows, physician trainees. kept Paul on their health insurance roll even after he became disabled. They just sort of like never told the system that they had this resident who had stopped working. And my employer, I was a postdoc at the time at Stanford, just said, let us know when you're coming back. We assume you're taking a few months where we won't see you. We're just going to keep paying you if that's okay. And I've heard a couple of really brilliant quotes along the way. And one is about, well, let me just put it this way. Those two things that happened to us did not come out of policy around really excellent sick leave or universal healthcare insurance or family medical leave. Like those were sort of ad hoc solutions that came to us from individual people. And so I think so much about how we were very lucky in many layers, right? Being physicians, understanding medications, understanding how to use the healthcare systems, having insurance that continued. And yet this was still so difficult and so existentially and practically challenging. And I think, you know, the two big things that came out of that time for us were Paul writing this memoir and us deciding to have a child. And those things wouldn't have been possible if there had been many other layers of struggle happening at the same time, which they are for most people. So I think a lot about our privilege in this situation and the real true privileges that we had. And I've been working more recently thinking about caregiver policy for caregivers at home and even domestic workers at home, and providing support in terms of payment and PPE and education and the things that people need to take care of each other. And I think during COVID, it's becoming so clear what happens when, or like the value of caregivers, right? The true value of caregivers in different forms. So, and like what it means to be a hero, right? Like in the hospital, but then also in nursing homes, long-term care facilities, homes, like the protections that people need. And so anyway, I've been thinking a lot about that. And I guess two other quotes that come to mind that sort of go along with this, tying back to what I said about Paul's employer, keeping him on the health insurance.
Beautiful.
So one is when I think about family caregivers, I have some colleagues at the Clinical Excellence Research Center at Stanford who wrote an op-ed about caregivers and a short research article about caregivers. And they said something like, the best long-term care insurance in America is an adult daughter,
Correct.
Which is wild, right? It's thinking about the extreme burden is a complicated word, but in terms of loss of income, et cetera, that family members take on. And I think about, you know, the best family leave policy is often a compassionate boss who's willing to break the rules like mine did. And so in terms of what is helpful, I think it's those things, but it's also the layers of structure that need to come out of what it is that caregivers need. Anyway, I feel like that was sort of a wending answer, but something important to reflect on. I know you think about a lot.
Well, we think about this a lot. In hospice, of course, we're caring not just for the patient, but the family or the caregivers, or the family and the caregivers. And I just shared with you a little earlier that in January, out of nowhere, very suddenly, my mother became ill, and I went up to the Pacific Northwest where she was living, and needed to take family leave, which just was such a burden of. And it's still, I just got paid for it last week. It was so, but the layers of burden, and then took time afterwards for disability, another incredible layer of burden, which I actually have never gotten paid for. And so, you know, that kind of stressor on top of caring for someone that you love. My mother, we were so fortunate because she was in a facility, and the caregivers, they were actually very caring. They loved her. They would come in and cry because they'd never seen her ever. She never called them. In the 3.5 years she lived there, she'd been incredibly independent. But I've been doing this work for 32 years. I was with her the night that she died. It was a very long 12 hours. I was feeling I just all night long thought, we ask so much. I'm a 62-year-old, fairly healthy person who's done this for 32 years and trained lots of people around this. What happens to this 90 or 80-year-old spouse of somebody
Yeah,
who's
totally.
that age? And where are the supports in this country for that kind of care? Because there actually are none. And so I'm very happy to hear you talking about this. I know Jess Sitter is exploring this with a new film. And it's just really
Yeah.
amazing to me that just the burden on families to provide
Yeah.
this care, and also the incredible, in some cases, benefit to people who are able to provide that kind of care. I'm so grateful that I was able to do that for my mother. It changed our relationship. And it sounds like with you and Paul, your relationship really evolved from the time that he was diagnosed until the time he died in some pretty beautiful ways and very heart-wrenching ways as well.
Can I interrupt and just mention
Yes.
2 organizations that I really like?
Yes.
Just in terms of, there's 2 organizations that are actually linked in terms of leadership that I, and these are national scope organizations. So this is in addition to organizations like yours that are locally embedded. But one is called Caring Across Generations, and the other is called Domestic Workers Alliance. And they're both focused on the types of policies that support caregivers in the home, particularly, but also in places like nursing homes or health systems that are outside of the hospital. And they work both on direct caregiver support and policy. And one of the big policies that has been devised by leadership within Caring Across Generations is something called universal family care. I don't know if you've seen this. It's really amazing. So it's a proposal. There's a really amazing article in the New York Times last year. I remember where I was when I read it because it's so revolutionary. So it's this proposal for something called universal family care, which would essentially be a social program analogous to Social Security or Medicare and Medicaid that would provide for care either for individual people or support as family caregivers, ranging from parental leave to care in the home so that people could stay at home, to family medical leave and that kind of thing. And at first you're like, well, how could it cover all of those things together? But then if you think about Social Security, that's also filling multiple gaps, right? Including disability and bereavement. And so this is structured the same way, and it would be a payroll tax in the same way that then would provide for all the needs we all have in terms of caring and caregiving across our lives. And it is so remarkable. And I think particularly in terms of being a feminist policy and a just policy is one of the coolest things that I've ever seen. And so I'm hoping that something like that will actually become something that becomes part of the Democratic platform. Now, ideally. But anyway, something for listeners to look at that just gave me so much hope because, translating this need into words and then into policy with teeth and money is really important. And I think many more people agree about the need and impetus behind that. Anyway.
No, so Lucy, that's
exciting
wonderful.
If people want to read about that.
Yeah, and we're going to send some resources to everybody that's on the meeting after the meeting is over, probably later this afternoon. We're going to send resources, so I'll get the URLs for these and send them out to everybody, and the New York Times article.
I can send that to you too.
That's beautiful. Yeah, I mean, this kind of policy, I think especially with COVID, and we just see how necessary it is to have people to care for other, I mean, we need something different to change here. And yes, it's primarily, I am the oldest daughter in my family. So yes. I know that we talked a little bit about your TED Med talk where you referred to something that was very, it was a godsend for our family that we'd happened to have a conversation with my mother a year before her death about about what she wanted, advanced care planning, basically. She was very clear with us. So my 4 siblings could be very aligned with each other around caring for her. And in your TED Med talk, you referred to advanced directives as an act of love, which I resonate with really strongly. Could you say some more about that?
Yeah, sure. So in that talk, I said something like, yeah, like completing an advance directive is an act of love. And in a way, it's similar to signing, making a marriage vow or signing a marriage certificate, where you're essentially signing up to love someone no matter what, and to be present for them and speak for them, and literally be there for them. And then I said, that was paperwork, but it became a part of our love story, a tangible part of our love story. And I think, I do think that, I guess a couple of things. Partly that commitment to being there during someone's illness or death is very profound and loving. And then I guess I sort of think an opposite thing as well. So I think it's like a very soulful, important commitment. But at the same time, I think about the paper part of it, which is actually a little bit flimsy and is like born out of relationship rather than paperwork. And I guess I'll just say what I think about that too. It looks like you have a sense of what I'm talking about, because so there's advanced care planning, right? And one big part of that is writing an advance directive and then naming a healthcare proxy, right? So there's the healthcare proxy who can speak for you if you can't speak for yourself, because you're too sick. And the advance directive part is essentially, well, it came out of sort of an autonomy movement where it was determined that people have the right to refuse medical care, which is like, okay, obviously, duh, right? That's important. So codify that. And then the next step was to say that you could designate someone else who could refuse medical care on your behalf or choose medical care on your behalf. So that's important too, in terms of autonomy. But then the situation in which this is often required is usually complicated in terms of uncertainty. You make all the decisions you can with the information you have, but it's often uncertain or complex. And then the person who's speaking for you has to take the medical information that they're getting, the probabilities, the nitty-gritty of what their decision-making might mean in terms of your future disease course, whether it means that you would definitely die, whether it means that you might be in a long-term care facility for a long time or forever, and how would that fit with you in terms of what you had expressed. And I think ultimately, when a healthcare proxy is making a decision on your behalf, they're trying to speak for what you would say if you could speak. It's not what they think for you. It's literally what you would say. And then, and that takes like not only loving you, but also knowing you really well and knowing what is important to you and knowing what kind of life you feel would be worth living or not. And that itself is an act of bravery and love, right? But it also requires relationship with you as a complicated person. So I almost think that paper gives someone the right to do something that then can't be done by any piece of paper, right? And you, when you sign an advance directive, can't really know what the situation will be and what the uncertainties will be. And I think part of the love that you then are giving the person that you were, so I'll just say something Paul said actually, because this is what I want to express. So I was named as Paul's healthcare proxy, and we were having a lot of conversations about his care and decision-making. And then at one point he said something like, I can tell that it's a big deal to potentially need to make decisions on my behalf if I can't. And he said something like, whatever you do, like let's say you end up regretting what happened. Like you think that I got some kind of invasive care that I wouldn't have wanted, or there's family conflict around that time, or whatever it might be. He said something like, I know that you're going to do your best. That's all you can do. And anyway, the last day of your life is not the sum of your life. The sum of your life is the sum of your life. And it's just like such a lifted weight for him, because I think there can be so much guilt or second guessing after somebody dies. Could I have done something differently? Did I do enough? Was I enough? And I think that idea of like, everybody always did their best and everybody's always doing their best, was like such a gift to have recognized. And I really think that's true as a doctor. So anyway, I think there's like a forward looking version of love, which is you give that gift of trust and then you say, I know you'll do your best.
Yes. Yeah, that's a beautiful story. It's really, and it's so true also that that those regrets, I mean, we in our bereavement department can talk all day long about people who have regrets, who feel like, you know, the second guessing, which I think is just human nature. Of course it is. And just to know that you have done the best, and to actually to have that conversation with somebody, spend a lot of time kind of talking about these things, and have a number of people who have said, well, you know, my loved one has just said, you know, that these are kind of big parameters that they have in mind for their treatment, and that they know that you know, if I'm making these decisions and they want me to make decisions that I can live with. And I thought that's also a gift to the person who's always going to be trying to do what's best for their loved one, and you know, is often caught between a rock and a hard place making decisions for people. And also just to acknowledge the importance of these conversations. It's we have a program through Mission Hospice called Take Charge for advanced care planning, and we recently moved it from sort of a, you know, experts or, you know, professionals to peer-to-peer, and trained some of our community ambassador volunteers who've had experience navigating these very difficult things, and the whole quality of the conversations changed. And
Interesting.
yeah, and
in what way?
I think people who were coming to, you know, complete their advanced directives felt more free to really talk about what was really of concern to them, and didn't feel like they needed to show up knowing more than they did. They could bring their fears and their concerns, and also, of course, their experiences, because people
like they were just as much as an expert.
Yes, that this was something, and of course we have information that we're, you know, giving them around statistics or, you know, probabilities, and really the important thing for us is that people have the conversation, that they don't just complete the paperwork like my mom and dad did and put it in a closet somewhere, and that we found out in our family about my father's advanced directives within 12 hours of his death, and we had no idea that they were in a lockbox down in the basement. So these kind of conversations.
But like you said, it still helped you be in alliance, right?
It helped. Yes, it helped me, because my brothers had a very different idea about what should be happening at that point in time. This was 20 years ago. And my father had very clearly written, I want as much medication as possible. He didn't believe he was going to die. So he wrote, if I ever am going to die, I want as much medication as possible. So we were giving him meds, and my brothers had concerns about the medication. And this is a very common hospice story. And so that he was very clear about that. My brothers.
And you're talking about a medication like morphine, right?
Correct. Morphine and Ativan to keep him comfortable, and morphine to treat the pain he was in. And they had concerns about him being as conscious as possible during his death. And so just having that in his own handwriting, where it wasn't about, oh, my, you know, my big sister's trying to shove this down my throat. It's like, no, actually, this is what our father had asked for. But at that point, it was like a different conversation we had. And so I've often said to parents, you know, the greatest gift you can give your children is a very clear directive and a conversation about this, so that they can, you know, put down whatever differences they may have. Even with very aligned families, this is such a tender and difficult time to navigate.
That's another form of love, right? It's so interesting to think about that, like in what it means as in a parental role to say what you will need from your children, but in a way you're parenting through that time too. That's really like helping them be siblings to each other. That's a really fascinating framing.
Yes, it was, and I mean, I have to say, with my father 20 years ago, we were in our 40s and 30s, and now we're in our 60s and 50s. And for my mother's death in January, it was just such a different and remarkable experience of just all of us being completely aligned and doing what it was that she wanted, and that was just our goal, as we were going to do what she wanted. The facility had a very different idea. That was also very interesting. So these kind of conversations with your family, with your friends, and if you're living in a facility, then also with the people there, so that they're clear about what it is that you want, as clear as you can be. This is very gray area. But I love framing this as an act of love. That is how I've experienced advanced directives. So I really appreciate that. You know, I'm kind of curious if there were things that, you know, in terms of the advanced directives, what Paul thought at the beginning of his illness that would be important to him in terms of advanced directives or conversations you had that changed as his disease became more, maybe it was clear from the very beginning, but I was wondering if this, you know, if the kinds of conversations you had changed during the course of his illness.
Well, I guess in a certain way. So in terms of the advanced directive, I remember, you know, he was diagnosed with an incurable illness. And of course, he had stage 4 lung cancer. And I remember it kind of early in the course of his illness, I said something like, you know, we should probably fill out your advanced directive. And he said, we should probably fill out your advanced directive, which is like funny in general, just about that need. And at least for everybody to have a healthcare proxy, right? And then I think in terms of the shifting conversation, you know, I guess the way I would think about that is the whole conversation about his medical care ended up being framed in terms of what was important to him in his life and what he was hoping to accomplish in the time that he had left. And so most of the conversation was in things like that. And that did carry through all the way to the end. And, you know, I think a lot of people who are ill, or maybe even in general, sort of develop a North Star of what is most important to them. And Paul's was the opportunity to be mentally lucid, and particularly to be spending time together with our family, and then to be writing. And he was writing When Breath Becomes Air up until a few days before he died, and was really writing furiously on it. And so that helped in terms of everything from, you know, medication choices or timing the medication so that he could have enough lucidity to write even while he was in pain, or taking medications that would make him more sleepy. You know, he ended up taking a stimulant medication so that he could have the focus required to write. And that was like an off-label medication that ultimately came from the palliative care team. It was really helpful. And then similarly, on the last day that he was alive, he was facing the decision about whether to be intubated and whether to go on a ventilator, breathing machine, and chose not to. And that was because the possibility of staying lucid and actually having more time that he felt was meaningful, that was very unlikely. But it's a really brave decision to make that choice. You know, it was very hard. It was very brave. And so anyway, but having that North Star meant that there was some clarity each time, and a way to frame the decision. So I guess that's the thing that I would say. And then, you know, at the beginning of Paul's illness, he was not receiving palliative care, and then he was. And so that was really helpful to involve a palliative care team at the same time as he was receiving care from the oncologist. So that's a kind of clear piece of advice that I would give as well.
Yeah, and I think that's something that people may not understand, that you know, people may just believe that palliative care is just hospice. It's at the end. It's just about comfort at the end.
Right.
And I think if you could just talk a little bit about that. How did that come
Yes.
about? Did his oncologist suggest that? I would guess maybe not, or maybe yes, or how did you get involved with palliative care?
Yeah, so we asked for it, and it's interesting because ASCO, the big clinical oncology society who writes guidelines, et cetera, says that for anybody who is facing advanced cancer, incurable cancer, concurrent palliative care, meaning seeing a palliative care team at the same time as seeing your oncologist, is standard of care. And it doesn't always happen, but it's useful to know, right, that oncology leaders are saying our patients are doing well with this. We want people to be doing this. And there's one really landmark study, at least one, but one really important early one from Massachusetts General Hospital. It was in the New England Journal of Medicine, that found that for patients who had I think it was stage 3 or stage 4 lung cancer, who received palliative care concurrently with their oncology care, not only had better quality of life markers in terms of things like anxiety and depression, but lived longer. So those patients actually lived longer, even though at the end of life, they actually received less intensive medical care, including things like hospitalizations. So that was really interesting to see, really amazing. And that jives with my observations as a physician. And then I think your point is very important, which is people often are not sure of the difference between hospice and palliative care, or think that they're the same thing, or think that palliative care only means end of life care. And I think the simple way to think about that, at least for me, is that hospice is for people who are, you had framed this so nicely before, and this is right. If you wouldn't be surprised that someone died within the next 6 months, then that person would be a good candidate for hospice and should consider hospice. So that is end of life. But hospice care is almost like a little subset of palliative care. And then palliative care is a medical specialty that's focused on quality of life, whatever that might mean. And it includes a team that could be a physician or advanced practice provider, like an NP or a physician assistant, nurses, social workers, a chaplain, and in multi dimensions of what quality of life might mean in terms of managing symptoms or thinking about existential distress or providing support for the family. And the locus of care is the patient and the family instead of just the patient. And then it's this team who's focused on quality of life. And so that can go straight alongside of even curative care for something that is a serious illness like lymphoma, for example. And then it's not just cancer. And initially this was big in terms of HIV AIDS, but this can be many other things like emphysema or heart failure or Parkinson's disease. So anybody who is struggling with quality of life. And so I feel like this is a really important part of care in advanced illness and terminal illness, certainly. And it's still something that not everybody gets and that you often have to ask for. And then when your team says, no, you're not ready for that, you can say everybody's ready for that if they're like ready for a better quality of life. So it's really worth asking for. And in many health systems, and Stanford is one of them, you can also refer yourself to palliative care. You don't actually need a referral.
Oh, that's interesting. Yeah, I think of palliative care as all the stuff that you would get in hospice, but you don't have to, it's everything you get in hospice, but you don't have to necessarily have 6 months or less to live, and you can continue to aggressively treat your illness, which is something in hospice that Medicare will pay for hospice care or aggressively treating your illness. So palliative care is available. And it's also just beautiful when people have palliative care, if they need to transition into hospice, though that kind of approach is very familiar because they're used to having somebody that would be interested in what kind of spiritual support might you need in addition to what kind of medical support you need, and really interested in who is this person, not just this is cancer that I have to treat. So I've
heard BJ Miller talk about and he's a palliative care physician who is a really good communicator and thinker. I've heard him talk about, if you could like explode the medical system and start it from scratch, you'd probably put palliative care right at the middle. Like, of course, this is what we're doing. Like, what else should we be doing if not thinking about quality of life in addition to aggressive treatment of a particular illness or extending life. So it's just so exciting. It is a revolution in itself in terms of medical culture. It's fabulous.
Yes, I've wondered, I'm old enough to remember like when we had a family physician that would come out with his black bag to our house.
Oh, really?
Oh, yeah.
Oh,
Dr. Borasek. Yeah. Or we'd go to his house where he had a little office and he knew everybody in our town because he was the doctor. And
where'd you grow up? Where was this?
Long Island, 30 miles from New York City in the 60s.
Interesting.
Yeah, in the 60s and 70s. Well, 60s in the beginning, late 50s, 60s in the beginning of the 70s. So like he knew our whole family. He knew everybody. He knew what we wanted. He knew everybody in the town. There was only one other doctor for 2 towns. And so it's been such an interesting thing to watch how medicine has changed so dramatically in my own lifetime that now we have a specialty called palliative care that's really about caring about the person. And I feel like, isn't that, that's kind of what medicine is about, caring for the person, but now it has to be specialized because everything else is a specialty.
Right.
But I'm so grateful that this exists. And I've also recommended to friends that have found themselves in emergent situations. A sister of a friend who was in the hospital for months with a horrible car accident and didn't know anything about palliative care. And once the palliative care team and they fought for the palliative care team because they kept saying, "You're not dying." And they're like, "Right." And we also, our whole life has been thrown up in the air, and we need support here. All of us need support. And once the palliative team came on board, everything just shifted and changed. And it was just, she continues to thank me. And I was like, I wish everybody knew about this and could advocate for themselves around it.
And I think there's something implicit too in the palliative care philosophy, which is non-abandonment.
Yes.
Like no matter what happens with your illness, or even when you're dying, like we will be here, we will be here, we will be here. And I think that's really important too, and very comforting and fortifying.
Yes, I completely, yes. That's a whole nother hour's worth of conversation there. I wanted to, I listened to your podcast the other day on meditative stories. And I was just so taken because this is really, you were telling the story about how your daughter, who's now 5, is that right? Has kind of navigated this. And I was struck with you saying that you're learning to see things as they are, which has also been a journey I've been on for about 30 years. And that you note with your daughter that this comes naturally to her because she doesn't have to unlearn anything. And I'm kind of wondering for you, maybe as a physician or, going through this experience with Paul, what was it that you unlearned that was maybe most helpful, or, what you see with your daughter, how she's navigating this is her natural, this death doesn't seem to, from the way I hear you talk about this about her, it's not a big scary thing. It's something that she has a relationship to.
Yeah, that's the most interesting part. So just in terms of raising my daughter, I think, I think what I am teaching my daughter, or what she is teaching me, is, she was 8 months old when Paul died, so she doesn't have a memory of Paul, but she's a kid who's growing up visiting a grave, and at first didn't know what a grave actually was. Like, she knew that we went there to remember Daddy, and she knew sometimes people seemed really sad there, and sometimes people are happy there because we're together. And so the idea of sort of growing up to be thinking about death and loss as just intertwined with our lives, I think. And she may have a reckoning that is different later, I think it'll be interesting to learn from her. But I think literally being unable to shield her is also a really obvious lesson in she can't be shielded and nobody can be shielded. And this is something, the same thing is happening in conversations right now around racism and justice. Sesame Street just did this incredible special about explaining racism to your children and saying things like, racism is a huge problem in our country. And this is what this is, 2 kids. And this is another thing that children don't have to unlearn, right? But it's still a public health intervention to teach them about what is actually also true in the world. So I don't know, and just an example, it's been so fascinating to raise a child who's a couple steps ahead of me in terms of making sense or just being wise. And a story, so the podcast that you're talking about is called Meditative Story, and it's a storytelling podcast that also includes these breaks for meditation. It's kind of a really interesting format. And I talked about, raising a kid who's navigating loss implicitly. And I tell a story about how Katie found a little party favor from my wedding to Paul. It's this little golden bell that is from India, and we gave them to everybody who came to the wedding. And I said, I told her what it was and said, that's a present that we gave everybody who came to my wedding with Daddy. And she said, oh, was I at the wedding with Daddy? And I said, no, you weren't even born yet. You weren't even born yet. And she said, oh, so I was in your tummy then. And I said, no, you weren't even in my tummy yet. And she said, oh, okay. Oh, that's because that's when I was dead. Like, so interesting, like mind-blowing sort of, right? This like conception of non-existence from a kid who also is like fine with the idea that her dad was here and now he's not, and she wasn't here and then now she is, and then they overlapped for a period of time, and that's how it is. It's just been really interesting to learn from her at the same time as I'm teaching her.
I loved that story, hearing that story so much. When my dad died, my niece was 13 months old, so I don't know that she had a very clear memory of him. The day that he died, the name that she called him, she started calling my mother instead, and she just did that.
Oh, interesting.
Which I found very interesting.
What was it?
Poppy. So she's 25, and when she was just with my mother in January, she still calls her Poppy. And that has just been what they've done their whole life. But when she was 3, my mother was babysitting for her, and she went over and Colleen came out to her, and she had these pictures, and she said, oh, hi, Poppy. This is what the old Poppy, this is what I drew when he came last night with those guys. And I was like, Mom, didn't you ask her? She goes, no, I just took the pictures. I was like, you didn't ask her about him and the guys? Like, what are you talking about? She said, no, she didn't know. I didn't want to go there with her. And I was like, I want to go there with her. But I just feel like kids are just so close to like the veil. I just, it's so beautiful. After my mother's death, my 9-year-old niece, there was a kind of a family discussion about whether she should come. And I was like, of course she should come. They have such a close relationship. It was very sad for her. She was beautiful with my mother. She led the way in terms of how we should be. We were not a demonstrative family. She got right up on the arm of the chair and put her arm around her. And then we all just did the same. And a couple of weeks ago, my sister-in-law called to say, Journey said to me the other day, Mommy, I think that our family does a good job with death. And she kind of explained, like, it was sad when Grandma died, and we really, we did what Grandma wanted, and it was good, and that, sometimes it's sad, but like we really think about all of the good times, and she really wants to remember all of the good times. And she said, I just think that we do a good job at death. And I felt like, mic drop, my job is done, I can retire now. But it's fascinating.
I like that she was saying it's both, right?
It's both.
That it's both.
It's both. Yeah. And I think, I love to talk about this with people because so often we have families with children who are really concerned and they want to protect their child. And we shouldn't talk about this in front of the kids. And I'm like, if you want to know what's going on in your family, ask your children, because they know absolutely everything.
Absolutely terrifying.
Yes.
Right.
Yeah, it is. And so, but I still see people, adults who are caring for their parents, who's an adult, who are there all of the time with the parent, and then they get up and use the restroom and mom dies, and they're just distraught because they're like, I abandoned her just at her last moment. I'm like, maybe it could be that your mom gets to protect you until she takes her last breath.
I know, I've heard a lot of stories.
Yeah,
it's very interesting.
It's fascinating, the role of parents and children, and how we navigate through these spaces with kids, and how our parents, until their last breath. And so many people that have said that to me about how they felt terrible that they weren't there at that moment. I said, maybe your mom or your dad was still in that parental role where they're still protecting you from their death. And we don't know, but there's so many ways to think about this. I also wanted to just ask you, I know that we're getting close to the time for Q&A. But this has fascinated me, Lucy, because your story with Paul, he died. He had finished the book. Is that correct? He had finished, except for the epilogue.
Yeah, more or less. Some of it, I can sort of tell that story or not, but his editor and I supplemented parts of it with writing that he had done in other contexts that were of a piece with the book.
Yes.
Or added things that he had taken notes on. Like the part about the anatomy lab, where he describes being in the anatomy lab as a medical student, and he talks about the reverse polarity of the cadavers, where when you're learning to do CPR on a mannequin, you pretend the mannequin's real, and when you're dissecting, you pretend that the cadaver is fake, and like what it means to grow into relationship with the body as an object, as a physician, talks about that. And he actually had written, that was a whole essay that he had written as a medical student, but he wrote a note that he wanted to add it into a particular section. And I was like, I know where that is. I know what that essay is. Let me go get that. So there's a lot of that actually.
Yes.
After Paul died, but no like ghostwriting or anything. It's all Paul's writing, but some of it was like made longer or supplemented and shaped. But yes, in answer to your question, I mean, it was basically done. All of it, the structure, the epigraph, almost all of the writing, etc.
He sounds like such an incredibly deep thinker and writer. And I wonder if the writing really helped him sort of navigate this illness. If he was discovering things in his writing about his own journey, if he was discovering things as he was writing, if that was.
Yeah, I mean, one of the conversations he had with his literary agent, because the book sort of came about fortuitously after he had written a couple of essays that went viral, that were reflections on the experience and were almost like personal, narrative essay and like diary entries in a way. There was one in the New York Times called "How Long Have I Got Left" that went viral and led to being solicited by agents and editors. And he had this conversation with the literary agent about how, as people who've read the book know, he had made this transition from being a quite cerebral young person who was thinking about mortality as sort of intellectually and thinking about bioethics and neuroscience, and then sort of made this decision that he wanted to become a physician so that he could tackle existential and ethical problems in a not abstract way, and became a physician and then became a neurosurgeon so that he's, thinking about identity, but also thinking about matter as identity. And he essentially like took himself into real people's lives instead of philosophizing only. Then when he got sick himself and had this illness, he ended up moving back into words to be able to make sense of it. I think he was pretty introverted. So part of this was just the way that he naturally processed his life, was like alone and introspectively and often through writing, but it also gave him like enough of a remove that he was able to actually grapple with what was going on for himself. So it was interesting to see him translate that back into words. And then it also functioned as a tool for us to be talking about some of the most difficult things to talk about, because I was sort of reading the manuscript in real time, like daily or weekly, and talking about it. So we're talking about a manuscript, and we're also talking about what was really happening. And similarly, like when I did the book tour for Paul after Paul died, which was also a very unexpected role, I felt like I was going on a book tour, but also able to connect with the experience of grief and have a way to talk. I think when someone's grieving, people sometimes don't know what to say, often don't know what to say, or can treat you with kid gloves or at a remove or not know what to say. But because Paul had done this writing, like people would come and ask me how the book was going, and it gave me a way to connect in grief as well. So it was very helpful.
Yeah, that was a question that I was going to ask you about, because, for many people, the death of their spouse is a paralyzing experience. Even, if they've planned and they've talked about death and I don't know if you had this experience when my sort of beloved died. We had talked about this for 5 years. And then he died, and I wasn't surprised that happened, but I was shocked. It was like a shocking, in my body, shocking experience.
It's like bizarre.
Whoa.
Yeah.
And now this has happened, and now I grieve alone. Like I'm grieving this myself because he's not here. And I wonder for you, because you were thrown into a very public spotlight while you were still, I don't know that we ever stop grieving.
Right.
It takes much different forms. We are able to navigate, kind of more consciously after time and work. But how was that for you to be so publicly grieving? And I also, when you were just speaking, it made me think about something somebody had shared a couple of weeks in a death cafe whose spouse died when they were also very young, and he's just shocked by how the friends do not want to say her name or talk about her because they feel like that will make him sad. And he's like,
right.
do they not get that?
It's like,
I notice every moment of my life he's not here, she's not here.
Totally. Yeah, I had the same experience. It's like, it doesn't remind you that they died.
Right. Like, oh yeah, I forgot they died. Oh,
right.
I'm so sorry.
It's like connecting and wonderful. Totally. Yeah, I had the same experience you had about it being so shocking, even if you know someone's going to die, right? Because it is so shocking. It's like they were here and they just disappear. Disappear. Yeah. It is so shocking. And for me, I think I had mentioned about how speaking about Paul, it's like literal strangers were asking me about Paul at a time when grief can be so stigmatized or isolating. That was very helpful. And then I also think, what was I just going to say? I lost it. Shoot. Hang on. Let me think for a second. Oh, weird. Oh, no. I was just going to say, what you were just describing of like, you have this very close relationship with somebody in a marriage and through caregiving, and then they disappear. And I felt like, helping finish the book for Paul and then do a book tour on Paul's behalf was a way to participate in the relationship. Raising our daughter is that forever, of course, yes. But there's something very sustaining, like going back to work was much harder for me than anything to do with working on the book, because I don't know, I felt like when someone dies, you sort of are like slowly molting a relationship. It's not like it disappears. You're still in it. And this is why I had written in the epilogue to Paul's book about this quote by C.S. Lewis that I really like. It's in A Grief Observed. And he says, bereavement is not the truncation of married love, but one of its regular phases. And he says something like, what we want is to love someone well and faithfully through that time too. And I think that's so true. It's like someone dies and the other person is still in the marriage in a way, even like when you fall in love again, etc. Like you still love this other person, you're still in relationship with them. And so there was a big part of it that was like wonderful to have that type of legacy project.
I'm curious what just this part of the conversation, I feel like I still am in a relationship 25 years later. I'm still in relationship with with Bob. And I just am curious if that is, if Paul is, I would imagine with Katie, your conversations about him or, keep him very sort of close at heart, even if you are falling in love with a different person who would have to be a pretty open-hearted person to understand that. When people die, my experience isn't like your relationships with them over. It transmutes and it's a different type of relationship.
Right.
Yeah.
Yeah, totally. I do feel like that. I mean, I think about Paul a lot. I think about the things Paul taught me. Katie is like a little brown version of me. She looks a lot like me as a child, but then her coloring is totally Paul's. So that's interesting to see. I mean, it's like very hard not to think about Paul all the time when I like catch the two of us in a mirror, for example, and it's like so clear that she is my child with somebody else because of the way that she looks. And then we talk about him a lot, like, I don't know, even in just little ways, like Paul really liked like boiling hot tubs and boiling hot showers, and I don't, and she does. And so she knows that she's similar to Daddy because of that. Just like many, many, many little details about the ways that they're similar. And that's been like helpful. And she asked about him. And then even right now we're in like very close with his family, who obviously will always be our family too. And so even now during COVID, like Paul's brother, his older brother, and my sister-in-law, who don't have children, moved in with us and they're sheltering in place with us. And that's been very helpful for me as a single mom. So,
oh my goodness.
Anyway.
Yeah. Without taking, I mean, this is going to be sort of a big left turn here, but I also know that you have been working, and then we are going to get to questions. I know that there's a question here, then we'll open it up for people to ask. But I know, Lucy, that you've been working kind of with people with COVID at Stanford in the last few months. And I'm wondering if you could just say a little bit about what that experience has been like for you as a physician, and also what you're seeing. I know that we were not slammed as hard as hospitals maybe in New York City or other parts of the country, but I would be very interested to know what that's been like to treat people. And
yeah, sure. So right now, I used to be a primary care doctor, and now I'm an urgent care doctor at Stanford. So I work in something called Stanford Express Care, which is like same day appointment urgent care, and we do 12-hour shifts, and it's like a hybrid between primary care and the emergency department in a way. It's very interesting. And I've been doing that for about 5 years. And then now our clinic is split into two, and it's Express Care and then COVID clinic, which is called Crown Clinic, which is kind of a cool name because coronavirus is like Crown. And so in both of them, we are seeing many video visits. So lots of things are video visits to help keep patients safe and us safe. And then in Crown Clinic, when we need to see a patient in person, then we have a special entrance and a special area, and we wear full PPE to see the patients. And it's been really interesting. So we're seeing the patients that we need to see in person are patients where when we do the video visit with them, we're not quite sure that they're safe to be at home. So we're seeing them to make sure, okay, do they need to go home, or do they need to go to the emergency department? We need to see them again tomorrow. And what's their oxygen level? And we're mailing patients pulse oximeters so they can check their oxygen level at home. It's been very dynamic and interesting to see all the ways that the health system can change very rapidly if there is will. And then I think the two striking things about COVID that everybody is noticing are what a lonely disease it is, what a lonely illness it is, and also just all the potential for moral distress around COVID. And so for me as a physician, initially the thing that was keeping me awake at night was thinking about what happens in a massive surge where you don't have the resources to take care of everybody. Then there are the major disparities in healthcare and how the burden of COVID is shouldered a lot by Black and Brown communities and essential workers, and nursing homes where people are not protected in the way that they should be, or who are already vulnerable in lots of ways. And so that's very stark. And I think the thinking around, okay, that's laying bare a lot of inequity, but laying it bare is not enough to fix it. It's always been there. And so the moral aspects of COVID are really important. And then also it's so lonely. And I think there's like many reasons for that. So shelter in place is lonely. And of course, being a COVID patient in the hospital is really lonely. It's like the patients who, and like people know people who have gone through this or gone through it themselves, where to be hospitalized, whether or not you have COVID, but particularly if you have COVID and you know that it can go south so quickly, and then you don't have a family member there, more likely to get delirious, very scared. And then the experience of seeing patients in PPE is isolating. We have a project at Stanford, and it's national and international, to have stickers with a picture of our smiling face on it, so that when we go to see the patients, there is because your whole outfit says to the patient, I don't want to be here, right? I want to be in the room with you. I'm covered up because I'm in the room with you. And then to have this smiling face on there, and the whole reason that you even took the time to make this sticker is to say, like, I want to smile at you, and if I can't, I'm going to do it a different way, and put this picture on myself. It's called the PPE Portrait Project. It's really awesome.
Oh, that's beautiful.
Started by Mary Beth Heffernan, who is an artist who started doing that during the Ebola crisis in Liberia, and then now it's everywhere. So anyway, and I think it's just been so wild to see this as such a lonely time in many ways. And so I don't know, those are some of the things that strike me about COVID. And the very, very loneliest version of it in a way is people who are having to say goodbye to loved ones or can't say goodbye to loved ones who are in the hospital.
Yeah.
And there's been a lot of leadership around that from Vital Talk in Seattle. And
Yes.
they even put out a COVID specific communication guide that includes the worst types of communication that can come out of COVID, like saying goodbye to a family, helping facilitate a goodbye over phone or an iPad, how to do that, and things like how to deliver the bad news of an immense surge and not being able to provide something like a ventilator or an ICU bed. It's wild. It's so instructive to read through that communication guide just as a historical document, let alone a living thing that we wish we didn't have to use.
Yeah, I'm going to recommend that our staff take a look at that if they have the time. I was thinking about this conversation a volunteer was telling me he had with his, they're doing phone support, and this gentleman, he was calling, his wife is the patient, and she's moved to a facility because he's not able to care for her at home. She doesn't have COVID, but she does have, I think, some form of dementia that was just making, they're both very advanced age. And he's 93 and his wife is, I think, 94. And he was just saying how sad he is because he doesn't think he'll ever see his wife again, even though she's alive and she's, a few miles away. And, for anybody that works in hospice, like those are very morally distressing situations because like you, our goal is to be with people, right, and to have their families to provide situations and support so they can be together. So that's happening in our hospice house. Families can visit there because we don't have COVID-19 patients, but we have lots of precautions about how they enter. They all have private exits out into a garden area so the family can come in through the garden door. They can just be in their room. They've put microwaves and refrigerators in all the rooms. They can use the patient's bathroom so they don't have to use the public bathrooms in the building, and the central part of the building, the staff, there's just nobody in it. So they're really trying to minimize.
And those were all changes that you've implemented during COVID?
Yes.
That's great.
In a month.
That's beautiful.
And then they can allow the volunteers to visit as well. They wear PPE as well, and they can be with patients. So, Yes, and so there's a couple of questions. Maybe we could transition to this part. And then I hope before we leave, I wanted to ask you, maybe at the end, if there was one thing that you think, if like you were thinking about Paul's voice, if there was some message he was giving to the community about preparing for their own death, what that might be. So just to give that some thought, but before the end of this, perhaps you could wrap this up with thinking about that. One of our volunteers, Cheryl Hilton, who's one of our community ambassadors, asking a question about palliative care and asking, is that scarce because there's a shortage of this medical specialty of people going into palliative care? Why is it difficult to access in a healthcare or hospital setting?
It's both. So if everybody who needed it had access to it, there would be a shortage. And so there's measures to increase training, and then there's also measures to train others to do what's called primary palliative care, which means you wouldn't be a specialist, but you have many of these skills that, again, we could argue that all healthcare providers should have. In terms of how to frame a conversation and how to build a team that supports patients and how to manage difficult symptoms and et cetera. So yeah, it's both. But then I think on an individual practical level, it's often that people aren't aware of it or are told that they don't need it.
Right, yes. Rosa Ruiz, who's also one of our community ambassadors, has made a note here that even patients that don't have COVID during illness became a victim of COVID in a different way because their families are not allowed to visit in the hospital or in a facility. So being alone in a hospital room was and still may be very present, even though COVID is not part of the equation. And yes, that's very difficult. And Alan has he's got his hand up here. Alan, can you unmute yourself? And you are welcome to ask your question.
Oh, thank you. Can you hear me okay?
Yes.
Okay, I need to ask a question about the issue that you guys brought up about sometimes difficulties for a proxy to know exactly what decisions to make. I had a younger brother that passed away about 2 years ago, and he was sick for a year. I was his sole family caregiver and was with him constantly, not necessarily 24/7. But I'm from Oregon. I'm a retired family doc, and he wanted to sign up for the Death with Dignity process here in Oregon, which we did, and we got the medication and so forth. His statement to me during his process of death was, when I decide that the quality of my life is no longer worth living, I want to use that medication. Well, it turned out, in my perspective, that his assessment of that quality was a moving target as his illness progressed. And at the last, he never used the medication. At the last of his illness, he was in incredible pain, with lots of fentanyl, lots of oxycodone. He could hardly move in bed without yelling and screaming out. Yet he never said, Alan, I need to take that medication. The quality of my life is no longer there. So in relationship to seeing this sort of moving target kind of a situation, and I think of myself, if I get COVID, I'm an elderly person, pretty good health, but I'm not sure I want to be on a ventilator, but I won't know that until I'm up against that right at that moment. So how does a proxy work with the patient when they see this kind of moving target of their decision making that may contradict their advance directive? That's my question.
Yeah. I don't totally know the answer to that, right? Because again, I don't know exactly how to answer that except to just say, I agree. And it makes it even more complicated because I think you're right. You can't always know how you would react until you get there. So I do think you just have to end up doing your best while also realizing that what you're saying is true. And maybe that some of that has to do with, if you are lucky, accompanying someone going through an illness and seeing that that is the case, that things shift over time like that. And I think like one thing that's bringing to mind is, like one of the formulations that I think about in terms of meaning in life is what Viktor Frankl talked about, where it's sort of like these three pillars of where meaning comes from. And he talks about work and love and suffering. And, like the work we do or the things we create are one aspect of meaning. And that includes things like a legacy project. And then love, meaning like love and gratitude for the world and participating in things like, for example, beautiful sunset, but then obviously love and relationships with other human beings writ large and with individuals in our lives. And then Frankl sort of posits another way of deriving meaning, which can be true in some cases, that is making meaning out of persisting through suffering or having made it through or to be going through something hard, and the intrinsic meaning of having fortitude during that, which isn't something we can demand of other people, but I think that does arise in some people. And so I wonder, like when I think about, I think you said it was your brother, your younger brother, I wonder whether work and legacy or love and connection or gratitude or persisting despite suffering, like remained meaningful to him in a way that he wouldn't have known in advance. I think that was the case for Paul. And in Man's Search for Meaning, Frankl also quotes Nietzsche, who said, "He who has a why to live can bear almost any how." And I think when you feel a sense of purpose or connection, that often is enough to sustain somebody. And so there's something to think about during those times, because what ends up giving you meaning may be something that you might not have expected or you might not think was possible. And then the flip side is like, you just do your best and try to let regret lift if possible.
Thank you.
Sorry for your loss, by the way.
Yes. Thank you for sharing that, Ellen. Larry Regan asked, in what ways did accompanying Paul through his illness and death change the way you interact with your patients, Lucy?
Well, I think, one way it did one big way is sort of recognizing caregivers and connecting with caregivers who are present, often a spouse or partner or an adult child. And then I think I sort of deepened or elevated, or whatever the word would be, my sense of healthcare as a very, very human endeavor, as much as it is a scientific one. And I think in my clinic that I was mentioning, we don't often deal with extremely ill patients or patients thinking about mortality, although COVID has changed that somewhat. But even in an encounter that is quite simple, like for example, someone who has a respiratory illness that's relatively mild and they're coming to find out whether they need an antibiotic or not. I think I used to like detail the risks and benefits of the antibiotic and try to talk someone out of that if they didn't need it, and take that in sort of a scientific direction when I was having even a conversation like that. And now I often will say, like, it sounds like you really feel like you need an antibiotic for this. Like, what are you hoping for from taking the antibiotic? And, you know, if it uncovers something else, like I don't want to have pneumonia and have somebody miss it, like happened to my friend on the street, or I have to do a presentation at work tomorrow that I absolutely cannot miss. And I need to be functioning for that. Like oftentimes, if I can get to that point where I understand, like, what is it that even brought someone here for something as simple as a cough, then I can recommend treatments that fit with what they're hoping for. And I know that sounds like, yeah, I don't know, it comes up all the time in my practice.
And I see that you're not really Larry, or possibly is that Larry back there? Do you want to ask, is there anything else? Does that answer your question there?
That does answer most of my question. I just didn't know if there were any other listening things that you could respond to when patients were talking, maybe a different response you'd have, but I think you're pretty much answering.
Yeah. Thank you. Lucy, we have Gloria here who's saying, it's great to hear you talk. I chose not to renew my license when California asked me to help with COVID surge. Miss seeing you and Katie. I'm your former neighbor.
Oh, wow. Cool. Nice to see you. You're a beautiful singer.
Oh, wow. Is there anybody else here that would like to hit the participant button and raise your hand here? We still probably have. Yes, please go ahead.
I had to unmute myself. I'm sorry. I had a question pertaining to you as a caregiver. My husband was diagnosed with metastatic breast cancer. He was given 24 to 30 months to live. We were dating at the time, but anyway, he lived 17 years. He just
Wow.
February 28th of 2020.
Wow.
But as a caregiver for so many years, I struggled with finding the balance. Take care of myself. Like you said, Paul said, everyone else needs to take care of you so that you can take care of him. But only in hindsight now do I see how much I really failed at taking care of myself. So do you have any words of wisdom, or how did you deal with being a caregiver? And now it's my time. I mean, I'm being selfish. It's all about me. But looking back, I mean, I think of other people I know as caregivers, and I'd love to help them in some way. But I failed miserably at taking care of me.
Yeah. I'm sorry for your loss too.
Thank you.
I think, so for me, it's like, there are a number of things that are proven in research to help people cope, right? And thrive. And they're relatively simple, but like, they're not rocket science, but we don't always do them, right? So, and there are things like adequate sleep and exercise, and mindfulness meditation is now on the list, and social connection, not being isolated, because that can be so true when you're a caregiver. And those things aren't always possible, certainly in combination, but I had gone through an episode of depression as a medical resident. So that was before Paul got sick. And I think having figured out what made me able to get through that time, I think I was so scared of becoming depressed again when Paul was sick and having postpartum depression, which was even a higher risk time, that I felt sort of like entitled is a weird word to use, but like sort of entitled, like if I become depressed and emotionally separate from Paul or unable to be a caregiver, like that's not going to work for anybody. And so I definitely need to be doing these few things. I think I was like trying to fortify myself against what felt like it could be one of the worst case scenarios. And so that was helpful to just feel kind of entitled as a safety measure, or, you know, really understanding the value of that self-protection. And then I bet you have so many good ideas in terms of supporting other caregivers, right? When you look back. But I think like helping people feel recognized and giving people a break, whether it's in terms of something as simple as delivering food or giving a food gift certificate, or giving them an actual break in time, or just recognizing what they're doing, I think can go a very long way.
Well, I think one thing you said too about, like with grief, people don't know what to say to you.
Mm-hmm, mm-hmm.
They also don't know what to say to you when you have someone that has
Yeah.
incurable
Yeah.
illness. And our friends definitely changed over the years, and people get, you know, it's a hard, and I mean, I wouldn't say I failed miserably, because I did take care of myself, but it was just in spurts. It wasn't a full-time trying, you know. So, but thank you for everything you're doing and bringing things into conversation right now.
Thanks for being here too.
Thank you.
I also just want to, I remember when I was caring for Bob that a lot of people, you know, people would call and ask me, like, what can I do? What can I do? Or you should get out of the hospital. You shouldn't be there. And I was very clear. I would just say to them, I'm going to be in the hospital until he dies. I was there about 6 months with him. Like, I would have friends that would bring clothes, and I would sometimes go out for a walk. But most of the time I was in the hospital with him. And I said to them, what's really important for me right now is that I can do this the way I can do this. And what's going to be really important for me when he dies is that you're still around. So for Linda, you know, I really just, you know, we can only do when we're a caregiver what we can actually do in that moment. And it would have been great if I was meditating every day. Some days I did, some days I wrote. A lot of days I didn't do any of those things because my primary focus was for the time that we had was to be with him. And so I hear your sort of and I also think back after the couple of years right after his death, is looking back and thinking, oh, should I have done that differently? And now many years later I realize, no, I did that exactly right. And I hope that for you that, you know, it sounds like you had an amazing 17 years. It's a lot to be in a relationship for 17 years when you have somebody who's, you know, their life is limited. And so I hope that you have a lot of loving kindness for yourself. And I'm so happy to hear that it's your time now. You'd go.
Yeah.
Take that time.
I like what
It has to be. I mean, especially with COVID, and I'm living alone for the first time in 41 years too.
Yes.
So, but
what wild timing.
Yes, what wild timing. Yes, this is, I want to thank everybody that's joined us today, Lucy. And I wonder, circling back to that question, like if Paul was going to say something to this group or to people that are interested in learning how to perhaps destigmatize ideas around death, dying, loss, and grief, if there's anything that you could hear him saying.
Well, this isn't totally about death and dying specifically. Although a little bit. I think I'll just share like the thing that I like most that Paul taught me and said to me, and he writes about it in the book, which was a conversation that we had around the time that we were deciding whether for me to try to get pregnant during that time. And he was pretty sure that he wanted to do it, that he wanted to have a child. And I was very worried about what it would mean for him I just didn't know what it would mean for him, whether it would feel, well, ultimately what I said something like, don't you think that having to say goodbye to a child will make dying more painful for you? And he said, wouldn't it be great if it did? And that I just felt like taught me so much about the fullness of what it means to be alive, and to be alive even when you're dying. And then just sort of the mix of pain and joy or beauty that can come all at once, and how the goal is not to try to live in a way that only minimizes suffering, but instead in a way that illuminates what's important and deepens meaning. And that was very helpful. I think about it all the time, and maybe I'll just say that wouldn't be great if it did.
Thank you. I can't imagine any better words to end our conversation on, Lucy. I am so grateful to you for being with us today, and to those that have joined us, thank you for your time. And please thank Katie for sharing her moment with us all this morning for a couple of hours. And we'll be sending a follow-up email, I'm hoping later this afternoon, to you all with some of the resources that Lucy has given us. So Lucy, thank you so much.
Thank you so much for having me.
Oh my
Thank
God.
you, everybody.